Welcome again to this fantastic meeting. I was amazed by the activity running in 3 rooms, and almost every room is full. So congratulations for the GIS board and scientific committee. It's amazing meeting. Can I have our panelists, please, on the stage? Dr. Abdullah Saidi, Dr. Ahmad Al-Qahtani, Afshin Ghufraniha, عارف نورياني, فهد الكندي, فهد القحطاني, طلال الجباري. The case will be a live case. The topic is TAVI. It will be a live case from Bordeaux University Hospital in France. The operator will be Dr. Thomas Medin. We tried to have a preparatory meeting to know the case, but it seems that he's having surprises. So we are blinded to the case. We'll wait for him to be live. So I'm waiting for the signal to be in contact with France, at least to present the case so that we can have a fair discussion before the procedure. Okay. Hello, France. Thomas.
Good morning. Good morning, Dubai.
Good afternoon, France.
It's lunchtime in France. We're happy to be with you.
I am Dr. Al-Utaybi. We are just starting the session with waiting for you guys. I have a distinguished panelist, and please, can we hear, after introducing your team, can we see the case, or can you present the case, please?
Yeah, I heard you when you were saying, so first of all, again, we are very happy to be with you for the GIS live transmission from Bordeaux. We are sorry that we will not be on site, but we cannot do both. I heard that we have been assisting to the last part of your discussions, and it sounded to be very animated between cardiology and surgery approach. Well, I can tell you that here in Bordeaux, we have a unique team, medical and surgical team. We work in the same unit. We look at the patients all together, and the pathway is validated, discussed by the cardiologists, the surgeons, the anesthesiologists who are in charge of the patient. So all the decisions are common. We wanted to present a live case for you using it to treat an aortic stenosis. The surprise is that we will be using a valve that just got the CE mark recently, and I think this is the first live transmission with this type of valve outside Europe, and you have the priority, of course, for it. So the team is Dr. Bonnet, Dr. Pierre Gentil, who are the interventional cardiologists with whom we will be doing the case. We have also, of course, the scrub team here. We have Karen from Medtronic, and we have Stefano as anesthesiologist. The patient is not intubated. There is no general anesthesia for this patient, as in our routine practice. So without any delay, and if you don't have any questions, Guillaume is going to present the case.
Yeah.
And then we will be discussing this topic further on.
Yeah, so first we are going to discuss the platform. So we use an Ethic Plus. So the innovation of this new platform is the larger windows to make more easier the access for future coronary injection and for future coronary angiogram. The ethics, maybe you are more familiar to this new platform with a lot of flexibility, control, predictability for the deployment, and also the nose part of the delivery system, who is less aggressive for the complex vascular access. Next slide. So if we want to just summarize the whole benefits of this new ethics system is the tip I've told you, the nose, very gentle for the vessel access. All the system is very flexible. That's a really difference and a big innovation in terms of flexibility, and also makes a lot of stability during the last step of the deployment. And another thing that we will try to show you during the deployment, and I think it's very important to respect, is the commissarial alignment. And with the 3 radio pack markers on the tower, directly on the valves, on the stent, you can precisely evaluate the commissarial alignment. So I think it's very important for everyone to try to do the best alignment possible. Next slide. So as you can see here on fluoroscopy, make difference between FX and FX Plus. It's the frame, you have these 2 windows in front of the 2 coronary, left and right, makes your life easier to access if you have any issue with the coronary. That's what you discussed previously. Sorry. Yeah. So here is a little animation to make you feel more quickly and more easily this new device. Next slide. And here is very practical. So for the commissarial alignment, as you know, we try to do a cusp overlap technique. So there is an overlap between the right and the left coronary, the left and the right leaflet. So you need to have this new marker, this new dot on the right part of the screen to make you respect the commissarial alignment. So this marker had to be isolated on the right side of the image. So here is a little animation to make it more easy to understand. So on the left part, there is a perfect alignment. Okay, as you can see, the commissarial of the valve are exactly as the native for commissure. Here is a little misalignment, so it's less than 40 degrees, moderate misalignment, and after severe misalignment. So it's something that we want to avoid, is to have not one marker isolated, but 2 markers on the right part of the image. So let's discuss all the cases.
Okay. So any questions so far with this choice of the device you wanted to share with you? So disadvantages, or you want to leave it to the end?
No, but we will go ahead, Thomas, but we were probably would have been a better idea if we presented the case to see what to choose. But now, since the device nicely presented, let's go with the case and then see the opinion of the panelist. Please go ahead.
Okay, so it's a female. I will say it's like between low and intermediate risk, daily routine practice with a mean gradient at 45. Symptomatics, of course, even if we know everything about early TAVR, we keep this indication of symptomatic patients with severe aortic stenosis. Not big past medical history. Just to be sure that we don't lose something, there is no conduction disorder, there is no significant CRD, and in terms of kidney, there is a good functional of the kidney. So let's do the CT analysis. So just to quickly do a summary of the CT analysis that we are going to do all together. The first is on the vascular size. We try to applicate the 2 score we published on this is all-style score and the aortic wall thrombosis score with very low, so no really challenging access for these valves can be available, and a good option also for complex access. And our aortic valve, it's not a smart annulus, but it's an intermediate annulus with a mean diameter derived from the perimeter at 24. And we would like to show you also the membranous septum. It could be interesting also for you to better predict the future conduction disorder after the procedures. In terms of the calculation, so I told you it's like between low and intermediate risk. So it's a good patient, good candidate for transfemoral TAVR with this platform about FX plus 29.
Okay, so as you've seen, this is a patient which is more and more, which profile is more and more common in our daily practice. Low to moderate risk, could have been a candidate for surgery, but we consider it better for TAVR. The gradient is high. We always assess the gradient also hemodynamically now for research purposes in all our patients before and after. We will show you this. She has some light coronary disease, so the choice of the device is very important. The key points of this is to discuss commercial alignment. Commercial alignment is very important for two reasons. I mean, surgically when we replace, we respect the commercial alignments, and this is mandatory. It could help guaranteeing an optimal flow throughout the LVOT tract and reduce the turbulences. This is one. The second is it will provide optimal access to coronary access, which are enhanced now with this platform that with a width of 2 cells that are more than 20 millimeters. So this width of cells is the biggest that you could see in the market today. So one of the discussions around the choice between self-expandable and balloon expandable is the access to the coronary access. And I think this iteration is essential to move forward with this therapy using self-expandable devices by guaranteeing the access to the coronaries that I hope will convince you it's doable here. Again, commercial alignment, cusp overlap are now part of best standards of practice to do any TAVR. We do it, and we have been doing this for the last for at least 4 or 5 years, even for balloon expandable devices.
Yeah, sure.
So commercial alignment is important for all the devices. Now what we do also here is that we do our CT analysis not only before the case, but during the case, and Guillaume is going to show you how we do it and how we assess this commercial alignment and the trajectory of the valves that we're going to implant.
Yeah, so previously I showed you the different vascular access. That's clearly on this last look analysis of the CT low risk. Here we use the Earth Navigator platform with this Philips Azurion hybrid room. So with the yellow dot, I show you the different leaflet. With the green dot, I show you the different commissures, so the native commissure. You have represented here on red the right ostia, right coronary ostia, and on the blue the left coronary ostia. So with these different markers, you have a very nice representation to be sure that you have the good angulation and it's make your life easier. Just something I will really want to show you because we have the time to take a quick look is the membranous septum. I think it's very interesting to assess in this context. So it's represented here with the blue line, light blue. So here you have this membranous septum is around 2.5. So this membranous septum is really depending of each patient. And if you do a subtraction of the depth implantation and this membranous septum where the left branch, so the coronary system is, you have a good assessment with the presence of a right branch block. A good assessment of your risk of congestion disorder after the procedures.
Yeah, one of the panelists was talking about shallow implant or deep implant, and I think we have to implant at the right level, I would say. And to implant at the right level is to get away, to minimize the risk of conduction abnormalities, and calculating the membranous septum depth is one of the ways to implant deep when you can without taking a risk, or the patient taking a risk to have an AV block.
Exactly.
Or high when you need to implant high. And in some patients, this membranous septum can be 6-7 millimeters, so you can implant deep very easily, especially now with this platform. Again, you don't have any fear to ignore the access to the coronary artery. So again, this membranous septum also calculated as part of our daily practice.
Thomas,
So
Thomas, if you allow us, you see, but Two issues here. Number one is coronary issue, and you correctly said about commissural alignment. I'm sure you calculated the sinus of Valsalva width and the STJ height, because this is very relevant, not only now, this is relevant in the next procedure. So can you tell us what are the diameter, dimension and height of STJ and the sinus of Valsalva diameter?
Yeah, so
they are represented here. So with
this is the sinotubular junction here, Azimuth.
yeah,
Wow. So this is the diameter of the sinotubular junction
with a height.
and the distance from the annulus to the STG. And we're gonna go a bit deeper at the level of the sinuses of Valsalva. You see it on the screen very well with this software.
Yeah, but the measurement is...
Click away.
what was the measurement of sinus of Valsalva?
Yeah, we're gonna show you. What will be the diameter? C'est lequel? De la Valsalva.
So the Valsalva sinus diameter derived from the perimeter is 30 millimeter. The annulus, so the mean diameter derived from the perimeter, also it's 24.2 millimeter.
So Dr. Alutaidi, we didn't draw the line because the perimeter helps us calculating the diameter. If you need more, we can do more.
No, it's okay.
Is that okay?
Yeah, that's fine. And
So this is a semi-automatic software. I mean, many of you may have it, and it makes our calculation much easier.
What software are you using? What kind of software is that?
It's a Heart Navigator system. It's linked with the Azurion Philips hybrid room that we use in daily practice. So we do the whole assessment with this category.
So this is the software which is integrated in our hybrid room, but I mean, we have the Tremensure, we have Materialize, that we can also put on our screen and analyze it lively.
Yeah.
so for the audience, so I think if you implant a self-expandable Medtronic, you need to know particularly about the sinus of Valsalva and the height and diameter of STG for this case and for a life management in the future. This is very important. The second point is, which you mentioned, is the membranous septum. And your measurement of membranous septum here is 1.5. And we know that your target in this particular platform is something around 3 millimeter. So how do you really entertain, how would you, I mean, the ECG is fine, sinus rhythm, no block, but how would you entertain that knowing the membranous septum is 1.5 and your landing zone will be 3 millimeter?
So Guillaume is calculating it. It's a bit more than 1.5. I agree with you. It's not always easy. So this is the case where we want, I mean, we could have chosen a case of, I would say, comfortable membranous septum, which is not the case here. I'm not sure that the 3 millimeter target of the implant must be absolutely respected. I think here, if we are 2 millimeters below the annulus, it will be fine for us. And this is also doable with this platform. I mean, I hope we will be able to show you this, to demonstrate it, because of the iterations and the improvements of the catheter itself. The flexibility give us better control. The final deployment self-centers the valve in the middle of the annulus. So we are able today almost to predict the landing zone. If you're not happy, we capture again and do it again. So we can show it, and I hope we will show you. I hope we will not need it.
Okay.
We can show you that it's more predictable. I
Fine.
just want to jump on one of your remarks. The width of the sinotubular junction is important for all platforms, not only for the self-expandable. Because if you have a small small sinuses of Valsalva, you have a high risk of coronary occlusion, and if you have a high risk of coronary occlusion, you have a risk of complication. And now the most important thing with this platform, more than the balloon expandable one, is to respect the commissural alignment, but also to keep overlap technique when you do the implant. So let's move.
Go ahead, Mo. Let's see in action. Okay, go ahead. Nice discussion. But we don't yeah, go ahead. You can discuss while you are working. So tell us your access.
Yes, so we show you what we do previously. So we do the puncture with the ultrasound guidance on the right femoral axis. So we have enough eye with the bifurcation. So we do triangulation to be sure that we show you the best.
So the puncture is not done using a micropuncture. We always do it under echo guided, and then we make a small injection using 7 milliliter of dye to assess that we are just above the bifurcation. I mean, although this could be assessed by echo, but we always double check by this small injection.
Okay.
So your primary axis is right femoral,
Yeah,
Absolutely.
and your secondary axis is
The left femoral, and then we cannot go carotid. The carotid is our first alternative.
yeah.
yeah. Go ahead. Can you tell us how far did you reach in the case, please, before being live?
Yeah, so we made the access, right femoral access, and left a radial artery. So this is our daily practice in all patients. One femoral, one radial access. It could be from the left, it could be from the right. It depends on the radial arteries. We always do this. Even for the carotid access, we always have radial access.
Just to finish the presentation, we also assess the valve before the implantation to be sure that the loading was okay. As you can see here, we take just consideration of these two systems are well positioned. And here you can see that there is just 3 or 3.5 cell with a very thin sur unfolding, but this unfolding can be acceptable if it's below 3.54. So for us, in organic practice, it's okay.
Okay.
The crimping is a bit different than the first generation.
So it's the usual, like the platform of Medtronic. You check it outside, you make sure of the pockets, you make sure of the prosthesis is not under tension. It's well prepared. Now, tell me, did you measure invasive hemodynamic monitoring when you cross?
Yes.
What
Yes.
was it, Thomas?
Yeah, because we don't use echo anymore, so we want to check that the numbers that have been provided by echo are okay. We're going to show you on the screen the results
Go ahead.
that we had.
Go ahead.
Remember, it was 45 on echo. This is Guillaume. Guillaume's going to show you the screen. We're going to enlarge it. You see, we have a full control of the panel here. And this also is very important for us. You don't depend on any information coming from outside the room. You have a full access and full control on all items.
Okay. We can see it now. What was the gradient peak to peak?
So peak to peak, it was 23, and the mean gradient was around 40. The ultrasound evaluation mean gradient was 45, so there is a little discrepancy between invasive and ultrasound. That's sometimes can make sense. And also we always do the assessment of the regurgitation index pre-procedural. So we have like we know where we come from to better know if there is an hemodynamic parameters for PVL.
It's a nice case. Usually the peak to peak corresponds to the mean echo, but that's fine. The other point which is irrelevant is the LV in diastolic pressure is not high. So it tells you that the LV is it's good to have some aortic regurgitation as a primed left ventricle, but it's not that significant to the degree of lifting the LVEDP. And you'll use it to calculate the AI index at the end of procedure if there is no echo in the room at least. So go ahead, Thomas. We are waiting for the procedure. So go ahead and we'll see you in action, okay? You can talk whenever you think you have to, otherwise we'll enjoy.
No, but also don't hesitate, and I hope the audience will be interacting with us. I mean, we are happy to discuss anything, even during the implant itself.
What pre-shaped wire you have?
We have, we're gonna, il faut mettre la pression artérielle.
Ouais.
Go on, give me 1 second, we're gonna connect it again. Since we started doing again the hemodynamic assessment, we discovered a lot of differences in many patients actually between the echo reports and the hemodynamic measurements. So we are trying to get more data on this to understand why is this happening and which one is more reliable.
Can you talk us through your procedure? Now you are going with the prosthesis.
Yeah, so this catheter has an inline sheath, so you don't have to insert it into another sheath. So for example, the E-sheath of the balloon expandable valve S3 or S4 now.
And it's the same advice,
French valve.
flush port at 3 o'clock.
Yes, we're gonna show you this. We're gonna show exactly. So we are already in the abdominal aorta. Now I'm gonna make a short stop here. We're gonna zoom a bit, and Guillaume's gonna explain to you how to position the valve to be sure, the catheter, to be sure that we're gonna go through the aortic arch with respect of a position that allows us to guarantee a cusp overlap.
So here it's very important to have this heart marker that you can see on the right part of the screen. We can show you here also.
He's gonna tell you about the
Perfect.
flash port.
Okay, so it shows that we can begin at 6, but if you take a look of the hat here, it's really on the external part of the aortic arch, and that's really important. You know, if you can see here, this is not a good position. It's not also. So the perfect position is really on this part, perfectly on the external part of the arch.
So what do you do? What do you do to make it perfect? Do you do counter or clockwise quarter rotation?
Exactly. Yeah, exactly. It's really slight counter and clockwise to be sure that you have a perfectly lesion at this at marker.
So you've been mentioning about putting the flash port at 3. It is not always the case actually. This is what you have to adapt it. You see the flash port here is at 6. Okay.
So what decides is
You can see. Yeah, go ahead.
so what decides is it the flush port entrance or the heart markers in the descending aorta? Which one you prefer?
The most important marker is the heart marker. Go.
The heart.
The heart marker, yeah. And to be sure also during all these aortic movements, to be sure that the heart is still on the external position. You can see that here, the heart marker is still in the external position. We can see with the mouse, with the, yeah, perfect. Okay?
Are you happy with this?
Yes. Is there a big tail?
Okay.
Well, how far from the, do you put, where is the relation between big tail?
Yeah, the pigtail has to be always like usually in the non-coronary sinus, in the bottom of the non-coronary sinus. Because this is the lowest part of the anatomy. And what we're doing here, we're gonna do 2 small injections, 15 each, at least 30 degrees away from each other, one on the right side of the patient, one on the left side. And we're gonna use them to do the commercial alignment. It's more reliable than doing this only based on the CT scan, which you can do also. Remember, in many patients, the position of the arm of the CT scan are different than the position in which you do the TAVR. So we are doing this live using the same software, Heart Navigator from Philips, and on which we already have all the dots that we have been showing you on the CT scan analysis before.
So as you can see on this fusion acquisition between CT and X-ray, there is always a slight difference between the angulation of the aorta during the CT acquisition and the angulation of the aorta with the device in during the procedures.
Is the big tail at the bottom of the non-coronary sinus?
Yeah, we're going to show you the angio that you've done already, yes?
Okay.
But this is a very important landmark. You're right to insist on it.
Okay, perfect. So we are going to check. You're right, maybe the detail is not perfectly in the non-coronary cusp, so we'll...
Vas-y, montre la longitude, je pense à y était. Vas-y. Check it, what we try.
Tu vois?
No, elle a bougé. Okay, it moved a bit.
So we take always a time to be sure that the detail is a good reference in the non-coronary cusp, like this. So perfect.
Is it better?
Yeah, certainly better, yes.
Yeah, slightly. Only slightly.
Okay.
Okay, so here we are going to show you what is the perfect commissural alignment.
C'est un peu hypertendu, non? La pression est un peu élevée, non? Rien, peut-être qu'elle est comme ça. I'll make a phone.
I don't know. I feel that this software, when it comes to this moment of the procedure, for me, it complicates the issue. You have to make a drawing. While there is NGO and there is a landmark, why don't we? I'm trying to create discussion here, and I'm sure you are good at this, guys. But we are trying to make use of this. Now, why don't we?
Listen, I agree with you. This is, we've taken our time to do it here to show you for educational purposes. I think all the audience is not as experienced as you and some other members of the panel, of course. But I think it's important to show you not only how we do it, but why we do it.
Certainly.
Honestly, on our daily practice, it takes 2 minutes. It doesn't... Listen, the patient is stable. Probably in this type of cases, it's not very important. The anatomy is very familiar, and it's a very usual case. But in other aspects, I think it could be very important and of a good help. And you know what? One of the things I think, the more we are treating young patients, asymptomatic patients, moderate stenosis patients, the better we should treat. And I think this is part of the process to be able to guarantee. Again, this discussion, if tomorrow we're going to tell the surgeons that we do a better job, and I am a surgeon, I think we have to be 100% of control of all the aspects of the deployment itself.
I agree with you.
But we have time. 1 hour to do a live case for a TAVR is... We can do 2 cases in 1 hour at least, you know that. So we're taking our time, and it's good to have it in such a comfortable way.
Yeah, we are enjoying it. We are enjoying it. Thanks for
Thank
the
you.
opportunity.
Okay.
Now,
I've said that,
Thomas, why you didn't pre-dilate?
because, look, if you remember the CT scan, I think it's a more fibrotic profile. Il a tourné la casquette. It's a more fibrotic. We don't have that much calcifications on the aortic band.
Non, c'est bon.
There is a question from Dr. Abdurrahman Al-Qahtani, pacing. What about pacing? Will you deploy under pacing or?
Yeah, we do fast pacing. You will see it. So we start without pacing, and just before approaching the edges on both sides, we're gonna... So you will see it here probably. We stimulate over the wire. You have the needle here.
Yeah,
The
sure.
alligator cable. So we are ready to do it.
Now, your landmark here is the marker of the platform to be at the lower edge of the big tail, if the big tail at the lower border of the non-coronary sinus.
Yes, exactly. And you see, we start very high. We know that by nature, this self-expandable device is going to dive a bit, and the target is to be around 2 millimeter.
And at this stage, do you hold it tight or let it go? Because it will descend for a little, like few millimeters.
No, I let it go exactly.
Okay, at this stage we can do the stimulation.
I just want to tell you something. So the patient is a bit hypertensive. The position of the wire makes it more prone to pop up than to dive. So I'm gonna let it like this, and if needed, I will maintain the position. But later on, again, I'm gonna wait to modify the position to when we start doing fast pacing. You will see it.
So Thomas, from here, I will not bother you. You just tell us, please, talk to us. I will not say a word.
Yeah. So now what we are observing is the depth. We are also going to look at the dots, the markers orientation. I'm not very happy with them. We don't have a perfect alignment.
Almost.
We're gonna make it better.
Yeah.
We just wanna see, I mean, this is a test. So we're doing rapid pacing in here, you can see it. The valve is open.
Okay. Pacing stop. So in terms of marker, it looks great. I think we have not a moderate. I think we have a good alignment if we consider that we are still in cusp of overlap. So you see that there is one isolated marker on the right part of the X-ray. So that's good. So very good. Yeah.
Avec la souris.
Yeah, here.
Va douce.
Okay. So this marker is isolated on the right part of the image, and you have these two other marker. They are with the commissure on the left part of the image. So for me, in terms of commissural alignment, I think it's good. After we have to discuss with Thomas, what do you think of the depth implantation? In this context, you know, of a modern septum was quite small, like 2 or 3 millimeter low. This depth of implantation looks pretty good. Maybe the QRS is a little larger, but there is no severe AV block.
Yeah.
Now, what do you think of the depth of implantation, Thomas?
I mean, for me, I'm not gonna go deeper, and then we cannot go shallower. So the enlargement of the ECG is not significant for me here. We are not pacing anymore.
So we do another control on LRO with the LCA, so the left cusp. I try also to avoid always the parallax of the valve, but to respect the S curve of the valve. And on the left part, it's okay, too.
So what do you think, guys? On this view, we can implant a bit higher, but again, listen, we have been implanting now for a couple of minutes, and then the valve is very stable.
What usually I do at this stage is to take a panoramic, make sure that the valve is not compressed at any direction. So I will go from extreme RAO to the LAO, panoramic, because the pressure is hemodynamic is stable. So make sure that things are okay. But the depth is fine, I agree with you. The depth is okay.
Yeah. So we're gonna do it for you.
No, you don't have to.
But I mean,
No, you don't have to. I'm just, this is what I will do usually.
No, you're right. Sometimes you have a problem of folding of the valve. You can see it.
It's a hurt team, we follow your leader.
Usuli.
So you can see that the image is not partially round, so
Yes.
for sure, if you take into account the first CT analysis and you do the right observation, it was not perfectly round. You know, there is always a longer diameter and a smaller diameter. So that makes sense that at the end, the valve respects, you know, the anatomy, and also it's something interesting to note. The system, the bioprothesis, it's supraannular. So maybe in this context, not perfectly round anatomy, maybe the valve could have a better gradient and a better morphology.
Happy with this?
Yes.
Okay, good.
Now, if you go to I like
Good. We have time.
No, I like that the whole platform, there is no much tension, because I felt that initially there was a tension. You are pulling, Thomas, on the system. It hugs the lesser curvature. Now it's in the middle. So now your hands are off. So I think there is no tension. So if it remains the same, I think that should be fine.
Yeah, so
I will take the opinion of the panelists. If you allow me, I will ask my panelists to comment one by one. What about the position? Thomas is asking, what about the positions? Open the mic, please.
But or just
Go ahead.
I think it's good. The three dots is not just aligned as we should, but I think it's good position. If there's no EKG changes, you don't need to change it. It's just like 1 millimeter just away from the. So the three dots, as I understand, should be at the level of the animal, just below it a little bit. So at this stage, I think EKG no changes, and I like the depth.
Abdurrahman.
I think the depth is good. It's almost have a cell, and when you deploy in the cusp of lab view, sometimes it looks like that you are quite deep on the left side. So you have to go a little to look into that properly. And I think based on the rotation or the spin that they did, it looks fine. So I think the depth is good. A marker also, if you see a sudden change in the conduction with the left bundle, then you kind of know that you're a bit deeper than usual. So.
So regarding the three big windows, I don't see it that evident on this platform. So the purpose of this FX plus is just to see where's the large dot, which is 4 times larger than the old cell. But I couldn't appreciate really the big window. So we're supposed to see the big window in different views to see if this is like a good commissioner alignment. Personally, I don't see it. Maybe it's far from here.
They could map it.
I mean, we will be an NGO with the. You want to do it now or when we do the final deployment? I mean, we are very confident about the perfect position of the valve.
Talal, what do you think? Position?
Yeah, I think the positions are great. I mean, it appears a little bit deeper in the under the left, but I think once you open the valve, it's going to tilt and it's going to be in a good position.
So you have approval from the
It's gonna get
panelists.
shorter, actually. It's gonna get shorter. Here it will not move anymore. This is the beauty of this new platform.
Yeah. So I would suggest you go ahead, take your time, deploy your valve, and then show us the windows.
So we do the final deployment with your advice. So with this ethics, we don't have to do any push anymore. So we are just in the middle of the aorta. As you can see with the pigtail, we see the external part of the arch, and we just slightly, the nitinol become warmer and warmer, and the deployment will be stable up.
We don't have the jump that we used to have before.
And as you
Now, this frame getting shorter or larger, when it gets larger, it has a tendency either to dive or to pop up.
Thomas, I noticed that your hands are off on the final release. Is that the way it should be done, or do you apply little tension forward?
No, we don't need to put any tension on it. This is the opposite of the Evolute FX platform. With this platform, no tension at all, not push. Just leave it as it is.
okay.
When you can maintain your hands on, but there is no push, no lay down on the other side of the aorta as you used to do before.
Okay, perfect.
So we're gonna go back in a couple of seconds. On va aller en position de l'implantation.
Ok.
Place overlap.
Ok.
On va montrer les dots à nouveau. So remember when you will see it on the right part of the screen. Essaie d'aligner un peu plus.
Ouais, mais avant que je
Voilà, voilà, c'est bon. You see, again, with the phantom of the software that we have used to mimic the anatomy of the patient on the right part of the screen, and you will have, zoom un peu plus, s'il te plaît. They do have markers which are very close to each other. On the left part of the screen, near my pigtail. On the right part of the screen, you have the single dot, single marker, which shows us immediately how likely we were in this cusp overlap. You remember that the red circle and the blue circle shows you the coronary arteries, which are aligned. And now, I mean, you can already tell that they are just in the middle of the coronary ostia. We're gonna do an ejection here, and you will see it.
We have just removed the pigtail with strap with a valve with a Terimo wire.
You can see it already, no?
Yeah, it's very clear.
Window.
But the way I see it, I don't know, is far away from the coronary. Will you engage the coronary and show us?
Yeah.
Yeah, if you want.
We're gonna do it.
Prendre JL, CGR.
Vas-y. Copy.
That's right. Yes.
Activate.
It's a was.
Ça suffit?
So you want to do it like both? Both.
No, c'est que ça. We're gonna show you on artery, if you agree.
It's okay.
That's to the proof of concept.
Yeah. So we do just a panel angio, we still have the safari wire in place, we don't see any outer regurgitation, so now maybe we can do a final invasive hemodynamic assessment with the different tail. Or we can also do the coronary angiogram if you want this. Or maybe the hemodynamic assessment, so 2 pigtails, please.
Yeah, on a 15 minutes, on a largement le temps.
Yes.
So, we will start by the hemodynamic assessment. When we leave the left ventricle, we did the coronary angio, okay?
Sure.
Tu l'as? Tire un peu sur le guide.
Yes.
Vas-y. Safari out. Vas-y, on lève le safari. Ok.
Diamond enough. And the point that's a cliff. Will you get
Okay. So now we do the
something?
So we do the hemodynamics assessment together in live. So as you can see, there is no clear gradient peak. Okay, so it's above 2. So that's why the third navigator system says it's not possible to assess the gradient because it's -2 millimeters of mercury. So actually on this system the gradient did not exist.
It's beautiful.
Okay. Okay, so now we can prove you the proof of concept of coronary angiogram.
Après, je te laisse.
Okay.
Big rats. 8. Similar kids.
Thomas, do you calculate the eye index or you just see the LVEDP or do you do final angiogram after 5 to 10 minutes, something like that?
We do all of these. I mean, the calculation is automatic, and then we will do the angio, of course.
How?
But again, I'm not sure we have to do all of them. My third personal thought is probably in younger patients, this has to be assessed. This is the best way really to know during follow-up if we have been doing the right thing or not. But honestly, I mean, listen, we have not been doing this for years. It didn't show to have any impact on our results. The durability with TAVR is super good so far. The gradient discussions that we used to have in the beginning didn't show any unfavorable outcome with the TAVR system. So, but we need to understand a bit more, for example, if the index of regurgitation is more reliable alone, or it should be coupled with the left ventricle anti-diastolic pressure on a large series of patients. So this is what we're doing this. Yeah. Remember Edwards, for example, claimed that echo measurements are not good enough and then hemodynamics should be assessed. And that's why in almost all the recent studies, they couple it with hemodynamic measurements, which makes sense.
Yeah, particularly going to the young, as you said, the young generation, and particularly in assessing the future of the structural valve degeneration, because the echo then becomes an issue, you see. So you might need, at certain stage, you might need to have invasive monitoring to be able to diagnose structural abnormalities.
Yeah, that's absolutely true. And you know, the problem with echo measurements is also you do one in the cath lab or the hybrid room, and then the day after it's done by somebody else, and at 1 week it's done by somebody else, and then at 1 month it's done by somebody else.
Sure.
It's too big. Yeah.
Do you undersize the catheter, diagnostic catheter, in the presence of TAVI?
Yeah, we could do this, but we use here a 5-wheel French diagnosis catheter. Okay.
To be honest with you, we do very few coronary access in this room. I mean, we're lucky probably, or we prepare the cases a bit better. And so we don't. So just to give you an idea about how our cath lab is organized, the hybrid room is closer to the surgical rooms, and the coronary cath lab is maybe 20-30 meters away from here. So all the coronary tools are not in our room.
Maybe the best way is to pass the wire, the J-tip wire, into the LV. Pass the wire into the LV, and then you pull it. Usually it pops up, the catheter pops up into the coronaries.
Yeah, the GL4 is maybe too much. Maybe we take the GL3 side. Okay.
Guillaume is under pressure. So Guillaume is our junior cardiologist.
It's okay. I won't insist on if you guys, you don't...
No, we have time. Let's do it. No, we want to do it. It's a good thing. Don't worry. We have time for discussion. We have to... So, I have a question for you. Who believe really that this cusp overlap with commissural alignment is important or not? Personally, as I've said in the beginning, even for manual expandable, this approach is really important. I mean, listen, even with the S3, we remember in the past, with the S3 used to have more pacemaker need than with the previous platform. And then since we started doing a cusp overlap using the S3 also, we reduced the pacemaker need to the historical level that we always had with the previous platform. So I don't know what you think about it, but for us it's very crucial.
Yeah, well, let me ask the panelist. Dr. Thomas saying about commissural alignment, even in all type of platforms.
Et on se met en position comme avec cette
Problem is, Talal, you want to take this? The problem is that how would you make sure of commissural alignment in some of the platforms without markers? Talal.
Yeah, I mean, for supraannular valves, it's a clearly, there is different ways how to approach for commercial alignment. For Evolute, we all know it. Boston as well, they do have, it's actually one of the easiest valve to achieve commercial alignment is Boston Scientific Dacron Neo. I guess the problem is with Sapien, the balloon expandable valve. I don't think we use commercial alignment routinely with that valve. I guess this is what we do in our center, but I don't know whether other centers that do that.
So I think commissural alignment, we came to know about them later on, when the initial valves that being used, people were not aware of them. And one of the reasons is because, you started with a lot of short valves where commissural alignments really doesn't matter because it doesn't affect your coronaries. and then you started having implanting the self-expanding valve in wide annulus and very spacious STJs and sinuses. So even though you are not aligned, you still have access to blood flowing right and left to those ones. But it became more apparent when we started pushing the envelope and doing more shallow sinuses with those devices. So I think it's very important because the height of the skirt that it goes in the area where you get the commissure joining, it's up to 26 millimeters. And if you have a shallow sinus with that, then you're kind of doomed. So it's important, and we always aim to achieve it currently. Yes, thank you.
I think if you see the evolution of the commissural alignment through the platform, so if I still remember when they started with the 3 dots and they did the study, the benchmark, and they said that the commissural alignment was accurate in 66% before the 3 dots marker. Then after the 3 dots markers, it's reached up to 95%. So the coronary axis, I think it's a major thing, and I think they are like doing much work on this, and now with the 3 windows and commissural alignment, we have more precision and predictable results with the 3 dots and large windows.
Dexter?
In my opinion, when we are concerned about severe coronary artery disease that a patient may have, it's better to think about the balloon expandable first, then go to itself.
Yeah?
With these new self-expandable valves, I think we will never be sure after the procedure what we have done. The rules are very important, but in practice, you should never be perfect.
So Thomas, in these cases, Thomas, when you, it sounds, I don't know, is it probably the type of catheters you have, or do you at this stage, we are not insisting by the way, but do you quit and do CT scan and double check your commissural alignment, or what will be the best course of action at this stage? Because this, obviously, this patient might be in a peripheral hospital in France, and they will have the same issue. They might find it difficult to engage. What is your advice for?
I mean, very, very humbly, we listen. We don't even have this syringe here. We have not been prepared to do it. So, and then again, just to give you an example, this is the 3rd implant of FX Plus. So we asked Medtronic to give us 3 FX Plus just to be ready to show you this platform. So first of all, I'm going to thank Medtronic for the support, and Dr. Fawaz for allowing this to happen for you guys. I mean, we are in a very friendly environment here, so we are telling you the truth. And also, I mean, Guillaume is a junior cardiologist with us, but probably in your hands, and then
And we are
faster and easier.
And we are very grateful for you to show us this valve and to show us this nice procedure, which took no time. But go ahead for the next step. Forget about the coronary if you.
No, we're done actually. Listen, I'm not sure you're interested in the closure of the femoral arteries. You have been done many times.
So
I
you
think
call.
the main topic of today. So yeah, we have a new cardiologist here. Benjamin is our senior cardiologist. So just to tell you, I think the bottom line of this live case, the interest is the new iterations are important with the self-expandable devices to move forward towards low-risk patients, younger patients, to guarantee an easier access to the coronaries. This is very important, and I think now this platform is ready for this big step. This is one. The second one is the best practices are commissural alignment, including for the balloon expandable device, and we can talk about it again later. And the cusp overlap, the cusp overlap technique, which is also very important for us. At that, the depth of the implant, taken into consideration the membranous septum, could be also a way to optimize the AV conduction abnormalities. especially that we are moving again to younger patients and low-risk patients. So this is the most important thing for me, and the demonstration of how effective this self-expandable Evolute FX Plus has become over time, which makes it very reliable and an excellent therapy for patients. Remember, we have many studies confirming now the importance of implanting this platform in many patients, especially with a small analyte.
Yeah.
So this is what we wanted to show you.
Thank you very much. You have shown it nicely, and I think there is, I've got received the sign that the time is over. And we thank you very much for this demonstration, for this straightforward case of TAVI, and for showing us the new platform of Medtronic. Thank you very much. Appreciate it. Thank you.
Jab.
Okay, thank you guys, and I'll be with you on Saturday.
You are welcome. Thank you.
Follow.
Thank you very much.
Bye-bye.
Goodbye.
Bye-bye.